Okay.
All right, what you're seeing is actually a group of critical care solutions. So there's separate views here for the different solutions. So in a nutshell, this one on the bottom in the second tier here is the documentation solution. So it's really the medical record, the actual chart. From that chart, if you want to use a virtual ICU or an EICU concept, you can launch a camera directly from the chart. So you can then zoom into a patient's room, you can look at their vent settings, you can read the labels on their IV bags. If we had a patient in the room, in the bed, you'd be able to, really see the detail about the patient. In the screen up above is another view of the chart, but it's intended to be kind of an always-on dashboard. And there's a number of tabs across this one. I'm going to switch it to a summary view, which will give you 12 hours worth of vital signs and vasopressor, antiarrhythmic, and pain and sedation medications on the left-hand side, 3 days worth of intake and output, and then your most recent lab and the one immediately prior. It gives you some respiratory data. And there's a number of tabs across the top that will also give you medication, the patient's medication profile, 24 hours worth of vital signs and hemodynamics, 7 days worth of intake and output, etc. So
what
I'll go
about
back
rhythm
to
trends?
that.
Or what about rhythm trends? Where are they? Because that's one of the concerns that people have now between, in the old days in the paper world,
Right.
the nurse would cut it out and you'd have it and you'd pick it up and you'd look at it.
Right.
Now, you have where to go, where to look.
Right. Well, actually, that's what this piece over here is. This is a partnership that we have with Cardiopulmonary Consulting, and they have essentially a number of dashboards. The one on the upper left is just a dashboard of the patients in your unit, so you can see the key clinical information coming from monitors and things like that. This is real-time data displaying in that kind of a tile view. Over on the left-hand side, by clicking on a tile, you then launch the individual rhythm strip for a patient. And if, in fact, your monitoring system has things like VTAC alerts, Bigemini alerts, those kinds of things, those can display like these alerts are already in the bottom here. They're patient-specific indicators. You can set high and low limits for the various parameters per patient, and then you can prioritize those alerts. So something like exceeding a respiratory rate might be in yellow, where asystole might be in red. And they can actually be in combination. So a heart rate of 0 in correlation with a blood pressure of 120/80 is not necessarily going to fire an alert, because it probably means the leads fell off.
And it probably shouldn't. I mean,
it probably shouldn't, exactly. So these alerts can be customized and can be, you can identify trends, you can identify combinations of data points that will give you the truly clinically valid alerts, but try to minimize the noise that often comes from some of these automated alerting systems.
But if I walk in the morning and I want to know, and invariably in the intensive care unit, there are multiple alarms that have gone off during the night.
Right.
Asystole, VTAC, and you put it on and you look at it and you say, I went back to the intensive, it was all artifact. Patient was scratching, doing that kind of stuff.
Actually, the real-time waveforms are at this separate pod over here because they're not yet FDA approved, so we can sort of get people's feedback about them, but we can't sell it, we can't market it. It's pending that approval.
But the intent would be that would be accessible in a station like this.
Correct. Alan?
For it to work.
Well, this is actually the setup that Clarion has, or a similar setup as what Clarion has in their virtual intensive care unit.
Okay.
So they have 4 pods in their ICU. They're monitoring, I believe, about 160 or 200 patients. Each pod has 40 patients or so loaded on it.
Okay.
So there would be these CPC monitors with the rhythm strips and the tile dashboard and the alerting for those 40 beds that I'm responsible for today. They would have the access to power chart. I don't believe they have iAware yet in their virtual ICU, but they do have the power chart. They have Apache. Apache 3 and Apache 4 have as capability is the ability for you to trend responses over time.
Okay.
So that was a Apache score of 33. You see here in the lower right-hand corner, an Apache score of 33. The arrow indicates that it's gone up by at least 10 points in the since yesterday. The pie chart will tell you where those points are coming from. So the bulk of them are coming from hemodynamic and cardiovascular instability. The next largest group is from the pulmonary and then the renal. They really don't have any problem in these other three categories.
And this is done by real-time data that's flowing directly from the monitors into the system?
It's flowing from power chart into the system.
Okay.
So it's
and so
verified.
the renal results will be either urine output,
right.
What about BUN creatinine, which would come out of the laboratory system?
Yeah, exactly.
Okay.
Yeah. So then over on the left-hand side, you see ICU risk of death displayed for today, hospital risk of death. This is the predicted length of stay in the intensive care unit. This is their actual. And once the actual exceeds prediction by more than 2 days, that will turn red just as a visual indicator of a longer length of stay than what was expected. This is hospital length of stay, and then actual prediction and actual hospital length of stay. This is TIS, the Therapeutic Intervention Scoring System. The upper number is the predicted today, the lower number is the predicted for tomorrow, and then the 0 in the middle is because they're not collecting actual TIS to compare actual to predicted, they're just working from the predictions. So this is the real-time data. Over here you've got the same kind of information displayed in text, and across the top, of course, it's trended. So you can see whether a patient is getting better, getting worse, is their mortality risk going up, is it coming down, that kind of thing. So hospital mortality is this green line. Let me get rid of ICU here so that it's a little clearer. Patient came in at a very low risk of death, has been there for almost 3 days, still has very low risk of death. The question is, why are they still there? Well, we know that they're ready for transfer because this little icon here indicates a potential transfer. So basically highlighting throughput issues, patients who are in ICU getting active ICU intervention versus those that are not. All of those little icons will highlight different things that you might want to know about the patient as you're managing their care. So this is the Apache detailed screen. The actual screen for the entire unit then just takes that and puts it in a snapshot.
So with this screen here, when you have the 40 beds up, does something alert you that, you know, this one says 0. I mean, I don't know whether 0 is good or bad, but does something alert you that says, okay, I got to be looking at this particular patient?
Well, it'll just be these up and down arrows as their physiology is changing.
Okay.
So the 0, though, means that the patient has perfectly normal physiology. So there's no derangement at all in their physiology. They're not getting any Apache points for deranged physiology.
Okay.
So again, the question is, why are they in the ICU if their physiology is normal? As opposed to, well, this patient right here doesn't have a terribly high score, but this patient has an active treatment icon, meaning they're getting some type of active ICU intervention. And I mean, maybe my score is low because I'm on 4 different vasopressors and some antiarrhythmics and I'm mechanically ventilated. So physiologically, I'm looking fine, but I'm only looking fine because we're intervening. That's what that indicator right here will tell me, as opposed to a patient who's looking fine just being monitored in the ICU. So a lot of different nuances in terms of understanding and interpreting the data.
Yep.
I'm not ready for discharge just because my physiology is low because I might be on 15 different interventions.
General death. All the numbers are perfect, but you still die.
So anyway, that's the Apache bed board, and now in the background there is then the ability to download the information or to maintain the information in a database, which you can then report on. So at the end of the month, you can say, what was my actual to predicted risk of death? What was my actual to predicted active treatment? You know, were patients staying too long in the intensive care unit? And if they were, who were they? Was it the surgical patients? Was it Dr. McDowell's patients? Was it the, you know, sepsis patients? Was it the patients on mechanical ventilation? So you can drill into that database then and really focus on areas where you're doing well and focus on areas where perhaps you have some opportunities for a performance improvement or a utilization improvement strategy that's very specific, diagnosis driven.